Welcome to Scale Up Your Practice, the podcast from Obesity Canada. I'm Dr. Roshan Abraham, a family physician and associate professor at the University of Alberta. In my work, I see every day how complex and challenging obesity can be and why our evolving care is so important.
And I'm Michelle McMillan, a lived experience advocate with Obesity Canada. This podcast is where we have honest conversations about how we can improve obesity care that's grounded in both evidence and empathy.
So for many people, sleep challenges can be a big part of their story, but they also can be left out of care conversations. Today, we're exploring why sleep matters and how we can build more holistic, supportive approaches to obesity care.
We're continuing our conversation with Dr. Michael Mack, who is a psychiatrist and a sleep medicine specialist at the Centre for Addiction and Mental Health in Toronto. Welcome back to the podcast, Dr. Mack.
Thanks for having me, Michelle.
In the previous podcast, we talked a little bit about this, about how sleep belongs in every conversation about overall health. And one of the things we do on this podcast is, there's a lot of things that are important for obesity care, but there are a lot of things we talk about that are good for everyone, right?
Mm-hmm.
When we talk about nutrition, when we talk about moving our bodies. And, I think sleep falls into that category, right? And so if we start at the beginning, as an expert, I'm going to ask you, why is sleep such a critical pillar for everyone's overall health?
Yeah, so we've all seen, let's say provincial and federal government investments in, getting the message out there for healthy nutrition and adequate exercise. When I was a young person, I don't know how many episodes of Participation I've watched with Hal Johnson, Joanne McLeod, about exercise. And then, they would also throw in, some tidbits about, good
Nutrition
diet,
as well.
nutrition, etc. And the truth is, sleep is the third pillar alongside those two pillars that ties them together. When we exercise, we are, putting our muscles and bones in a state of stress. We're straining them. We're putting them to the points of limit sometimes so that we can build greater and greater exercise capacity, increasing our strength and endurance. And in that process, those things get broken down. And of course, we eat to live and to survive, and also for on a personal basis, I eat for enjoyment. But that gives us the building blocks on which our muscles and bones and other facets of our bodies are being repaired. And the time that occurs is not while we're awake; it's while we're asleep. So that really ties together those two concepts: nutrition, exercise, sleep. As Roshan has mentioned in the last episode, it's a non-negotiable part of human life. We spend a third of our days essentially in sleep, and it's the time when our muscles and bones are being repaired. It's also the time when we do growing. It's the time when we learn. All the things that let's say if we're going to school and we're studying our textbooks, that kind of information is encoded in working memory and short-term memory. But if we want to be able to take facts back at will and do well in school and put into play things that we learned, whether it's riding a bicycle, driving a car, playing a piano, these are things that are solidified in sleep. And I'm not just telling you this and making it up. There's science that backs this. For all those people out there, they're still studying for exams, young people, you got to have that sleep after you've done your cramming for it to integrate. And we know that you're going to get higher marks than that. So the truth is, it not only is it non-negotiable, it's something that is not passive. There are ways that we can improve sleep on an active basis. So, I'm delighted to be here to get our message out there.
I think an extension of that in primary care, you mentioned the participation imagery is just beautiful because that was such a huge you could say it was a public health effort, right? In not so recent times, to really improve the way that we looked at exercise, and to a certain degree, as you mentioned, nutrition, and yet sleep was left out of that. Why do you think sleep can be left out of those conversations, but more importantly, so many of our care conversations, especially in primary care?
Well, I think, clinically speaking, like if we're talking about, people that we work with, colleagues of ours, any sort of clinician, I don't think we have enough education out there, to be honest, that, pushes sleep as something to be asked about, to be screened for, as like sort of like a forefront of all care contact. Not, it doesn't matter what kind of medicine or clinical care that you provide. Um, so I think that, one part of it is education. And the second part is we simply don't have a lot of advocates that, let's say, push for, that bring, sleep as an important part of our lives, to everyone's, thoughts. I think that that's changing, though. And I think that,
Hmm.
and it's based on, work that, that I'm doing with you. Um, we have a Canadian Sleep Society that represents the interests of Canadian sleep researchers and clinicians. And we do advocacy work alongside our sister organization, the Canadian Sleep Consortium. So we actually have visited Parliament Hill to try to convince senators and MPs to enact, health-related bills that add investment into, sleep health and bring to the forefront the idea of sleep health alongside the pre-existing investments in nutrition and exercise. So there's, right, like, lack of let's say education, that it's an important thing, lack of advocacy. And the third part is, I think all of us have assumptions. There is still stigma towards, sleep, that it's not that important. It's a passive thing. You just,
Yeah.
at night when it gets dark, close your eyes and you're going to go to sleep automatically. And if you don't sleep well, there's something wrong with you.
Yep.
You must have done something. So, and we see that echoed. We see that reflected in our care for people living with obesity. So, it makes perfect sense for me when I see that there's so much overlap, and that's why I think we have a great opportunity to work together. And, improving sleep health is improving health in people with obesity.
Yeah, I mean, I think that's so important to highlight to our listeners because um, both you, Dr. Mack, and Roshan, you've shared that you're both good sleepers. I am not. And when we talk about the getting less than 6 hours sleep a night, that's me. And it's not that, you know, I think people don't realize that they want more sleep. Trust me, I want more sleep. But I think, you know, the complexity of it's not just lie down, close your eyes
Yeah.
and be out for 7 hours. If it was, I think I'm a reasonably intelligent human being. I think I could handle those instructions. And so I guess my question would be, you know, while it's simple to try to encourage people to sleep more, it's a complex relationship with getting more sleep. And so maybe I'll get you, if you can kind of untangle that a little bit, that it's not quite as easy as it might sound and the reasons why it's not quite so easy as it sounds.
The first part is asking if people have sleep problems, right? The second part
Hmm.
is not to tell people, oh, just go ahead and sleep better, because that's never going to work. In the history of humankind, anybody if you tell somebody, don't think of pink elephants, all they're going to do is think of pink elephants. We saw that in a movie, Ghostbusters 1, if
Goes.
you're of a certain
Yeah.
vintage, right? Dan Aykroyd, he thought the most benign thing he could think of. And then, of course, what they call the Stay Puft Marshmallow Man, which is like
Yeah.
it's a corruption
Oh
of
my
Michelin Man,
God.
came to
What
attack them.
imagery.
Yeah, to
Wow.
destroy New York City, and they saved them, and also there was Bill Murray and everybody. But so yes, the second piece, right, the intervention piece, the part where you make efforts to improve sleep, that is not as simple as just letting things occur passively. So in that aspect, I want to bring attention to something called cognitive behavioral therapy for insomnia. So I mentioned before that there's insomnia symptoms that may come and go, but if you have it at nighttime, it causes daytime dysfunction, and it's there for 3 months, 3 times a week for 3 months straight. That kind of insomnia demands treatment, and the treatment would be cognitive behavioral therapy for insomnia, which is a very short, time limited type of therapy. And we're not going to be asking you about your childhood. It's not about that. We give people very practical ideas and methods to improve their nighttime sleep. So, as one example, if a person has trouble falling asleep and staying asleep habitually, We want them not to stay in bed when as they're being, lying there wide awake, right? Because sleep is subject to the psychological concept of conditioning. The more
Hmm.
often you're awake, wide awake in bed, the more likely it is for you to have more, sleepless nights, because your brain's going to think it's totally okay to be in bed, not asleep. So that's where having, some assistance, whether it's from, a doctor or some other form of healthcare clinician or social worker, is going to, really help and improve a person's sleep. Also, I want to, before I forget, there's also, a place here to rule out the other related sleeping disorders that can mess up a person's sleep quality. So we talked about sleep apnea before, and it's very easy to screen for. Does the person snore? Do they have a neo hypertension that's been diagnosed? Do they have excessive daytime sleepiness? And there's some other metrics, like let's say, male patients are more likely to have it compared to female patients. You can look at neck circumference, waist circumference,
Hmm.
etc., as a way to have a pre-test probability, like without having to send somebody for a sleep study. What is the estimated risk that this person has a sleep-related breathing disorder? But something else that needs to be focused on is also the presence of restless leg syndrome. It's a very
Yeah.
common reason why people have poor sleep quality, have trouble falling asleep and staying asleep. And we know that people living with obesity, their odds ratio of having restless leg syndrome is like 1.44. They're much more likely to report this condition. So correcting all the other ancillary, like all those auxiliary type of sleep disorders that go towards decreasing sleep quality, is also part of this comprehensive sleep care for everyone.
I think this is actually a great opportunity to unpack some of the biological, behavioral, and psychological forces that keep people feeling stuck when it comes to sleep. Um, could you expand a bit more on the bidirectional relationship between poor sleep and obesity as it pertains to hormones, appetite?
Yeah. So so previously we talked about sleep duration. People with sleep duration that's too long, so defined as 9 hours or more, habitually, that's associated with increased body weight and obesity. Probably because that person is not expending their metabolic expenditure is not high enough. There's probably not They're not engaging in necessary physical activity. And then there's the opposite side: people with short sleep duration, and usually that's less than 7 hours, and it gets much worse when you're less than 6 hours. And there, we start having especially if the person has insomnia disorder, we see inappropriate activation of inflammatory factor secretion. So things like interleukin 6, tumor
Hmm.
necrosis factor alpha, um, a reduction of insulin sensitivity in response to eating. So we talked about that, and on top of that, there's also this circadian influence on weight and sleep. So if, we're all of us, we're governed by an internal body clock, and our internal body clock regulates bodily processes to make sure that it makes sense that your body is doing a certain thing or focused on a certain task when it's appropriate. So during the day when it's light out, we need to be having good physical strength, having good physical endurance, concentration. Our cognition should be at its highest. Our alertness and vigilance should be at its highest. And then at nighttime, when it's dark out, there's going to be other things that need to be processed. So one example is when we sleep, our immune system starts to build for the next day in preparation for more physical and social contact with people that might carry germs. So there's actually studies now that demonstrate that there are suggested times for let's say eating, and suggested times not for eating.
Hmm.
So one mismatch that can occur is if a person tends to, wait until very, very late to eat.
Hmm.
We know that for whatever reason, that's associated with more increases in weight, even if the person is taking in the same number of calories.
Hmm.
Let's say at 6 p.m. versus 10 p.m. Same number of calories, but increased weight from the later time. So, lots of experiments are being done. At some point, we'll be able to give get a better idea, yeah, as to what types of interventions that we can institute on a day to day level that doesn't require doctors.
Yeah. And that As usual, learning new things on the podcast. Love it, right? Because that simplistic, calories in, calories out, it's so much more complex than that, you know? And just what you were saying about timing and whether that, I can't even imagine the complexities of it. It's not simply, I'm sure, a direct yes, we see the correlation between when people eat and the impact of body weight, but all of that messy stuff in the middle of the why is the stuff that's hard, right? Is it hormones? Is it metabolism? There's so many things to unpack. So yeah, thank you for starting the conversation about it, because it's important, very
Hmm.
important.
Let me just close the circle on those other sleep disorders and how it might,
Hmm.
the pathophysiology of how it might cause obesity. So in people with sleep apnea, right? We know that increased weight is a risk factor for having and developing that condition. But we know that people who suffer from sleep apnea, because of their substantial excessive daytime sleepiness, they're less likely to be able to engage in physical exercise. They're more likely to crave caloric dense foods, especially if they sleep, short sleep duration again. And we also now know that in people who are night owls, people who have a tendency to sleep late and wake up late, as opposed to morning larks who like to sleep early and wake up early. Night owls have a tendency to have greater caloric intake, and uh, cravings for carbohydrates and things like that can affect one's weight. So there's even more factors, and I could go on and sit here and dominate the conversation, but I'm not going to do that. I'm going to turn it back to you guys.
Oh, I kind of want to ask you something, because this is something I hear from my patients all the time. What's causing some of that late night eating, that push for it? Is there something that we know that's I guess flipping that switch on? Because I would have to say most people have experienced that at some point in time in their lives, and so we can understand that. And then for some people, it plays a substantial role in their overall health and well-being.
Yeah, like in sleep medicine, we study uh, many let's say sleep or time related eating disorders. One of which is night eating disorder.
Yeah.
We know that people, let's say if they're under stress, like let's say a person that's like stress levels like 50 versus a person that's stress levels 85, the person with higher stress is going to have a tendency to have more to have greater hunger, particularly close to bedtime. And we know that has to do with changes to ghrelin secretion and leptin secretion. Moreover, when we see people who are like, let's say they're suffering from depression, there is a tendency to eat more close to bedtime.
Right. Right.
Now I just have to explore this for one more second, and then we can get off the, the topic. But I just find it so fascinating. Do we know, we can see that people are eating more later in the evening? Do we know why above? Is it simply a correlation between lack of sleep and this, or is there something that's being researched that's being happening in the middle?
Right now, I think our understanding of like what influences the timing of a person's, like, let's say time of hunger, or like their desire to have like a meal like later on in the day, is probably multifactorial. It's probably not just coming down to just any one factor. I think one identified factor is one's chronotype. So when I talk about being a morning lark versus being a night owl, we know that night
Right.
owls disproportionately will eat more later on at night, and really eat dense calories. We know that there's going to be another factor there, which is the mental health side. So people who are undergoing more stress, having affective disorders like depression or anxiety, I think those people are going to have that sort of same drive. And then the third side would be physical disorders. So um, people sleep, like in the context of sleep, having let's say sleep apnea, um, other internal body clock issues. I think that these are all, factors that govern, that tendency to eat at a certain time.
I'd love to shift our focus to some of the practical ways, because there's so much coming to my mind about what I should be asking my patients. And we had talked in the last podcast about, do you wake up feeling refreshed, right? As being one of those questions, as a simple screening question. Are there any other simple screening questions that clinicians should be asking about sleep in patients with obesity? You mentioned the morning lark versus the night owl. I kind of like that too, if it helps hone in on maybe a certain time at which patients are maybe eating a little bit more.
Yeah, like if we're talking about just one question, right? Like, in my head, in my world, I'm always trying to think of things that are, high enough resolution that we're, being sensitive and be able to capture diseases that are there, but also being specific to know that, there are bad things that we need to treat. But if we're talking about just one question, um, a nice flip side to the original question that we talked about the last episode, which was, you know, um, after a good night, after your average night's sleep, when you wake up in the morning, do you feel refreshed enough to get through your day to do the things that you want to do and need to do? Right. That's the original
Yeah.
question.
Yeah.
Flip side is, after your average sleep, are there times in your day where you're feeling so sleepy that you can't do what you need to do?
Hmm.
And those two questions don't answer the same thing.
No, they
Uh,
don't.
Interesting.
so
Yeah. Yes.
that's my opinion.
I like that. I really like that.
Yes. So I guess another thing I'd like to explore is that, and maybe I'm stealing Roshan's question, maybe here, as a family physician, um, I guess in a world of unlimited resources, we could send everyone who said that they didn't feel refreshed in the morning off for, a full sleep workup. I don't know if that's possible in our
It's a good
systems.
point.
Like, that's not happening.
It's a very good point.
So I guess, considering our audience, right, of healthcare practitioners, do you have any advice for some basic sleep hygiene or behavioral strategies that they could start with their patients who aren't feeling refreshed before they, move to the next steps?
Yeah, if the most common issue that you're going to encounter, right, is just the person that says that they have poor sleep quality, and then
Hmm.
that's yes or no. The question after that is it because you have problems falling asleep or staying asleep? Like earlier on in this episode, I mentioned that there's the cognitive behavioral therapy for insomnia, and accessing this therapy, historically speaking, has been very, very difficult. Right,
Yeah.
a lot of therapists, they're not doctors, they're not covered by public health care.
Mm.
And to receive therapy, sometimes it costs anywhere between, let's say, $100 to $200 per hour. So
Correct.
to mitigate, right, to bridge that like sort of gap between supply and demand, there are we're leveraging the use of technology. So something that's very simple, like if a person needs CBT for insomnia, and instead of having to look for a good trained therapist, first of all, second of all, being able to pay for it, there are free smartphone apps
Hmm.
that deliver this therapy. So one study that we did with our old student, now colleague, Dr. Armin Rahmani, in conjunction with Colin Carney, who's the director of the Sleep and Depression Laboratory at the Toronto Metropolitan University, we looked at what were validated applications that actually give CBTI on your phone, because a lot of them just play relaxing music, or like
Yeah,
the sound,
exactly.
the
Yeah.
sound of like the beach, which I love and enjoy recreationally. But there's no evidence that that treats insomnia. So about the validated CBTI apps, so things that we can access here in Canada. So there's CBTI Coach,
Hmm.
and if your phone is like from like a different country, and your app stores from a different market, it might be Insomnia Coach, but those two things are the same, and it's free. And it comes with its own integrated sleep tracker, right? To find
Yeah.
out, where you're at is one half of the battle, right? So I think that's one tip that's useful. And other things that you can that you can look into. Let's say if the person, being like, let's say if I'm focused on, let's say people living with obesity, I think asking if they snore is an obvious question. If they snore and if they have sleepiness, That might be the time to refer to, like, let's say, a sleep center for home sleep apnea test. If you're, as an
Yeah.
example, you guys are in Alberta and out west, home sleep apnea testing is available. If you're on Ontario, you're most likely coming into a lab. There's nothing wrong
Ooh.
with referring on when you have suspicion that a person has sleep apnea to get that sleep test. Um, and let's say we want to be good stewards of the public healthcare resources and funds. Well, there's a simple questionnaire, and I'm sure we've all heard of it, Stop Bang Questionnaire, which was developed around the corner from us at the Toronto Western Hospital by Francis Chung, who's an anesthesiologist and the resident chair of critical care anesthesiology and sleep medicine. Um, 8-question questionnaire, very simple, and if you score 5 to 8 in this questionnaire, then you probably have sleep apnea. Less than that, you might want to think about it, right? So, these are sort of the resources and steps that I would point, for our clinician audience to consider.
I'd I'd love to pick your brain actually about AI, because I'd be curious to see whether or not any future apps or programs might actually utilize AI around CBTI, because that's always been an interest of mine. But I want to bring it back to the primary care perspective, and oftentimes patients are coming in. I actually can't remember the last time somebody came to me with their chief concern on my electronic medical record as being sleep, right? It's usually fatigue or mood issues or anxiety concerns or something else, right? Um, how can patients be empowered to bring sleep concerns forward and really self advocate?
Yeah, like in that situation, right? Like, that's where public, like, podcasts like this is very helpful, and also like public engagement. Um, for anybody that doesn't feel fully refreshed, doesn't have the energy to get through their day, there's periods of the day where you have to take a nap. In the absence of substantial, like, medical comorbidities, like, that shouldn't be the case. So I think that for anyone that has trouble falling asleep and staying asleep, so these are material things that you can, that you're aware of about your own sleep. If you wake up, 4 or 5 times, you're, peeing in the middle of the night constantly. I think these are all signs for, the patient side to consider going to see your medical professional and asking for, a checkup, at least, having that screen to see whether, you need to go to do a sleep test or not, etc. It also helps when you have people that can give you, hints and tips. So usually I'm talking about bed partners. If, you share a
Right.
bedroom with somebody, right? So, they'll be able to tell you if you snore, if you sleepwalk or sleep talk or not, if you grind your teeth, if you stop breathing. So having, somebody in your family that can bear witness to your sleep just even once in a while is very helpful. I don't know how many times, like, patients have been referred for assessment of sleep apnea because they went on, like, their once yearly trip with their kids. They went on, like, a cruise, or like they
Yeah.
shared it, like, hotel room, and they're like, wow, I had to, like, sleep in the hallway, in the staircase, and my back's broken now because of your runaway train snoring. Which, by the way, I learned I have sleep apnea because of that. Uh,
No way.
I have terrible sleep apnea, so I'm not.
Oh, wow.
Yeah, I'm not just. I'm not just. The president of the hair. Company. I'm also a client. You talk about practicing what you preach. Uh, Here we are. Uh, so I think, like, to go back on the topic. A simple tip that everyone can share with their patients or clients is to ask them to wake up every day at the same time, and then go to
Yeah.
sleep only when you're feeling sleepy, which is defined by that head nodding feeling that we get, right? If, we're at a meeting for 45 minutes straight, you look around, people are nodding their heads involuntarily because they're sleepy. So your wake time, if you keep it consistent Monday to Friday and into the weekends, right? Most people don't do that. There's a difference between their school and work week and their time off, and you're giving yourself artificial jet lag. And that, again, that artificial jet lag increases risk of overweight and obesity and inappropriate eating. So you don't give yourself that social jet lag if you keep a wake time every day at the same time. It stabilizes your internal body clock, because when you wake up is also the proxy for the time when you're exposed to sunlight and artificial lighting for the first time, which sets our internal body clock. And don't try to go to sleep every night at the same time. It's never going to work out, because when you feel sleepy at night, it depends on what you did during the day and if you
During the
had a
day.
relaxing time, right? If you watch TV for 4 hours and you read a book for 15 minutes and you had a nice meal, you're not going to feel sleepy as sleepy as the day that you went to the gym, and then you did something mentally strenuous. You did 4 presentations. You're going to be sleepy earlier because you extended yourself more. So your sleep time will be different from night to night, but try to wake up every day at the same time. That's the simplest way to improve sleep quality.
That's awesome.
Yeah, I love that because it kind of flips things on head. Most of us kind of have a standard go to sleep time. And, Monday to Friday, the alarm clock goes off because we have jobs and children and things that have to go. And on Saturday and Sunday, if you have a Monday to Friday job, you're like, oh, my indulgence, alarm clock's off. I'm going to sleep till I sleep. So, yeah, as someone who suffers from not sleeping well, I'm going to take that away from this podcast. And yeah, flip that. Bedtime is when I'm sleepy, and wake time is going to be the same time, as close
That's
as I can
awesome.
every day. So
I
thank you.
I'll volunteer. I don't have a choice. I've got a 5-year-old and a 2-year-old. They wake me up at the same time every single day. So I have a built-in evolutionary alarm clock. But I think once they get older, I will definitely take this into account because I can definitely see that happening.
True.
Yeah.
And it also speaks to children, right?
Mm-hmm.
So you just said what evolutionary or biologically we need, right? Your children go to sleep, they wake up at the same time every day, regardless of.
Every day.
I know.
Every day.
I know it doesn't help you, but um, I guess, we've talked about how things are now. And I similarly have been diagnosed with sleep apnea. So, I'd be interested if you could maybe explore where you think the future of dealing with sleeping disorders is going, and will we ever not have to wear the Darth Vader mask at night? That's what I want to know.
I think that that's a realistic expectation at this point. At some point, we're going to get there. I mean, I don't want to name specific medications, but it's very exciting. It's a very exciting time. I just came back like not too long ago, like maybe 2 weeks ago from Seattle, which was our American sleep conference, and we see more and more data, from specific GLP-1 agonists, where alongside substantial weight loss, there's a huge reduction of the apneic hypopneic index. That's the number of times per
Yeah.
hour that you stop breathing.
Yeah.
It's our way to categorize apnea from mild, moderate to severe.
Severe, yeah.
In the original trial, led by Atul Malhotra at UCSD, along with all these geniuses in sleep apnea, they enrolled people that wore CPAP or no CPAP, but on average, they had terrible sleep apnea. Their average AHI was 50
Whew.
in both groups.
Whoa.
50 times an hour, you stop breathing for 10 seconds or more. So it's almost
Wow.
once a minute that you stop breathing for 10 seconds or more. And obviously, it's not just 10 seconds. Like, if you look at
Yeah.
that, it's probably going to be more than 10 seconds on average per person. So they were able, at the end of a year, after getting this treatment by injection, like the reduction of the apneic hypopneic index was something like, in both groups, the CPAP and no CPAP group was huge. It was like 25 to 27 apneas per hour. And
Wow.
it like more than half, I think, or about half, were able to achieve the threshold below which we would tell people to stop wearing CPAP,
Just wow.
which is defined as
Wow.
going down below 5 apneas per hour, which is
Yeah.
the most obvious. No apnea, 0 to 5 times an hour. And then the second one is, let's say they have like mild apnea, so 5 to 14.999, but no obvious sleepiness and no
Mm-hmm.
cardiometabolic comorbidities. And we say that in that situation, treatment is optional, so we can tell people to stop CPAP. So I think we are getting to the stage where we're like, maybe not having to wear CPAP is a realistic future expectation.
Wow.
Oh.
Wow. I am taking that with me. I 50 to 20, like that is a mind-boggling change. I mean, I knew there was research being done in this. I haven't looked at the studies myself. Thank you for sharing that. That is incredibly relevant emerging research that we're seeing now,
I,
that can change the way that we look at sleep and obesity.
yeah, and like we know that we're also improving their diabetes. We
Hmm.
know that they're also improving other cardiometabolic conditions like alongside the sleep apnea and the obesity itself. And to be honest, I'm just happy. I'm very lucky. When I was a young person, I worked in retail, so I knew how to sell things that were inherently not sellable. So my experience at the flea market selling uh,
Oh my
old
goodness.
school calculators for my uncle directly allowed me to sell CPAP to
Oh my goodness.
right because it's a selling process. Nobody grows up and says I'm going to wear like a full face mask like a jet pilot or like a nasal mask or even the smallest ones nasal pillows. It's an adjustment, especially if they're not people that wear glasses. They've never had anything on their face before, and um, in the context of a person with both conditions, obesity and sleep apnea, I think that that's going to be a game changer. The question is, where is it going to sit alongside the other pre-existing treatments? We have CPAP, which is the gold standard currently. We have mandibular advancement devices, which are effective for mild to moderate sleep apnea. There's two types of surgeries: uvulopharyngeal palatoplasty and then mandibular advancement surgery, where they actually, they break the muscle. Sorry, they shift the configuration of your bones in your face and jaw. Um, and where does this sit in the matrix of treatments? So it's a very exciting time for all of us.
So much to unpack there, but I think we actually have to wrap up. And with that, I mean, I loved hearing just the I think the potential that's out there for the conversations that we have with patients around sleep. I know we talked about it in the last podcast, so I really loved hearing that. It's energized me in my practice and sort of what I'll bring even tomorrow to really think about asking about sleep. We talked about it before. Is there one thing you really want to highlight that every clinician listening should take away when it comes to implementing into their practice around sleep?
Um, Please ask questions about sleep in all your patients, whether you're a primary care physician, if you're a psychiatrist, an
Yeah.
internist, if you're a surgeon. We know that improvements, let's say sleep that's poor, is going to lead to detriment of outcomes no matter what kind of treatment that you're proposing or implementing or procedure that you're doing. And preserving good sleep or instituting good sleep means the opposite. So just keep it on top of your mind.
Thank you again, Dr. Michael Mack, for joining us on the podcast today. If you have enjoyed today's episode, make sure you follow or subscribe to the podcast so you're notified when the next episode is live.
And if you found today's conversation helpful, as I definitely have, share it with a colleague, a friend, a relative, and you can help us out by leaving a quick rating or review. That helps more people find us, get more information, and have them join this amazing conversation. Thank you so much for listening. Until next time, stay curious, stay kind, and keep scaling up your practice.
This podcast is intended for informational and educational purposes only and does not constitute medical advice. The content shared in this podcast should never be used as a substitute for professional medical advice, diagnosis, or treatment. Always seek the guidance of a qualified healthcare professional with any questions you may have regarding your health or a medical condition. The information and treatments discussed in this podcast are based on Canadian guidelines and approved practices as of the time of recording. If you are listening from outside of Canada,
Please consult your local healthcare professional to ensure compliance with your region's medical standards, guidelines, and recommendations. The creators of this podcast disclaim all liability for any decisions or actions taken based on the content discussed. Listening to this podcast does not establish a professional or patient-client relationship.